there. So, you're gearing up for your NHA or CPT certification? You are in exactly the right place. Think of this as me, your virtual mentor, sitting right here with you. We're going to break down the whole venipuncture process into clear, easy-to-digest steps. My goal is to help you build the confidence you need, not just to ace your exam, but to feel great when you're on the floor. Ready? Let's get into it. Okay, so here's our game plan. We're going to walk through the 6 crucial stages of a perfect draw, starting with final checks, then moving to anchoring and entry, the all-important order of draw, how to mix and handle the tubes, finishing up with your patient, and finally, labeling and transport. Getting this sequence down is absolutely key for patient safety and for making sure your samples are perfect. All right, first up, final checks. You know, those few moments right before the needle goes in are so critical. Getting this stage right helps prevent a ton of errors, it protects your patient, and it really ensures the quality of your sample from the get-go. Look, every single one of these steps is a safety net. You only reapply that tourniquet when you are absolutely ready to stick. And please, remember that 1-minute rule. Any longer and you risk something called hemoconcentration, where the blood gets too concentrated, which can totally throw off the test results. Give the vein one last feel to confirm its path. Then uncap that needle and give it a quick inspection. And finally, glance at your tubes one last time. Are they the right ones? Are they expired? You want everything absolutely perfect before that needle even thinks about going in. Okay, listen up because this is a big one. It's a non-negotiable rule, and you will definitely see this on your exam. Once you've cleaned that site, you cannot touch it again. Period. If you do, you have to clean it all over again and let it air dry. Breaking that sterile field is a major error in the real world, and it's an automatic fail on your test. All right, let's move on to section 2, anchoring and entry. This is where the real hands-on skill comes into play. You know, a good technique isn't just about hitting the vein. It's about doing it safely and smoothly, with as little discomfort for the patient as possible. You know those pesky rolling veins? Well, anchoring is your secret weapon against them. By putting your thumb an inch or two below the site and pulling the skin taut, you're creating a nice, stable platform. It sounds simple, but this one action keeps the vein from wiggling away as the needle goes in. And it's so important to hold that anchor until you see blood flowing into the first tube. If you let go too soon, the needle can slip right out. Now, your angle of entry is not one size fits all. It totally depends on where you're drawing from. For those big, deep veins in the crook of the elbow, the antecubital, a 15 to 30 degree angle is perfect. But when you're on the back of the hand, where those veins are right under the surface, you've got to go much shallower, just 10 to 15 degrees. Going in too steep on a hand vein is a super common mistake, and you'll go right through it. And of course, always bevel up. No exceptions. Okay, let's talk about that moment of panic, the one every new phlebotomist has nightmares about. You do everything right, you get a perfect puncture, you pop in the tube, and nothing. Crickets. The key is, don't panic. There are a few small, totally acceptable things you can do. The key here is subtlety. We're talking tiny, gentle adjustments. Think you might be a little too shallow? Just advance it forward a millimeter or two. Think you went all the way through? Just pull back ever so slightly. If the bevel might be pressed against the vein wall, a tiny little rotation can get the blood flowing. Now, what you absolutely cannot do is start fishing around under the skin. You know that big sweeping motion? That's a huge no-no. That's how you cause serious pain and ugly hematomas. Okay, success. We have blood flow. Now we're diving into what is arguably one of the most important and most tested parts of phlebotomy, the order of draw. This isn't just a friendly suggestion. It's a fundamental rule of the lab. So why is there this super strict order of draw? It all comes down to preventing one single problem: additive carryover. Every time you switch tubes, a tiny microscopic drop of the stuff from the first tube can get carried into the next one on the needle. If your tubes are out of order, that little bit of contamination can completely ruin the test results. So here it is, the standard order of draw. You've got to burn this into your brain. Blood cultures are always first, no question, to keep things sterile. Then that light blue top for clotting tests. Its results are super sensitive to any other additives. Then come your serum tubes, then heparin, and then EDTA. Getting this wrong has some pretty serious consequences. Okay, lean in for this one. I can almost guarantee you'll see a question about this on your exam. The EDTA in that lavender tube, its whole job is to grab onto calcium. Think of it like a little Pac-Man gobbling up all the calcium in the sample. So if even a tiny bit of that gets into the serum tube before you measure calcium, well, your result is going to be falsely low, which could lead to a wrong diagnosis. Remember, serum tubes before lavender tubes, every single time. Okay, so you've nailed the order of draw. Awesome, but we're not done yet. The next critical phase happens right there, at the patient's chair. You have to make sure the tubes are filled right and mixed right away so the additives can do their jobs. First up, that light blue top. The second it's full, it needs 3 to 4 gentle inversions. This just makes sure the anticoagulant gets mixed in evenly to stop any clots from forming. And it's also vital that this tube is filled right up to the line. That 9-to-1 ratio is non-negotiable for coagulation tests to be accurate. Moving on to the gold or tiger top tubes, your SSTs. They've got a clot activator sprayed on the inside, and they need 5 gentle inversions. This makes sure the blood washes over that activator so you get a nice, complete clot before it goes in the centrifuge. And for our last group, the green, lavender, and gray tubes, they all get 8 gentle inversions. And when I say inversion, I mean a slow, graceful 180-degree turn of the wrist and back. We are gently mixing, not making a cocktail. Shaking is the enemy. Shaking is one of the main ways you can cause hemolysis. Let's talk about hemolysis. When red blood cells burst. It's one of the top reasons labs reject a sample. And the frustrating part? It's almost always preventable, and it usually happens right at the chair. Using a needle that's too small, sticking the patient while the alcohol is still wet, or shaking the tubes can all cause it. The good news is you have total control over this. Use the right technique, and you'll avoid it. All right, we've got our samples. Now our focus snaps right back to the patient. Finishing the procedure safely and professionally is just as important as the draw itself. This next sequence of events needs to become pure muscle memory. It should be automatic. Tourniquet comes off, last tube comes out, needle comes out smoothly, and gauze goes on with pressure. Your very next action, immediately, is to click that safety device on the needle. Don't even think about it, just do it. It's for your safety. Once it's safe, the whole thing goes straight into the sharps container. Here's another huge tip, both for your exam and for real life. Don't let your patient bend their arm up to hold the gauze. Think about it. When you bend your arm, you're creating a little pocket under the skin. Blood can easily leak out of the puncture site and fill that pocket. And boom, you've got a nasty bruise, a hematoma. The right way is to have them keep their arms straight and apply firm pressure. We're on the home stretch now, our final section. You've done an amazing job so far. This last part, labeling and handling, is what makes sure all that hard work actually pays off with an accurate result for the correct patient. This is a golden rule. You label the tubes at the patient's side. Never, ever walk away with unlabeled tubes. Every label needs at least 2 unique patient identifiers, usually their full name and date of birth. And you don't just read it off the label you printed, you confirm it with them or their wristband. After that, add the date, the time, and your initials. An unlabeled tube is a useless tube. It's as simple as that. And last but not least, always check for special handling instructions. These aren't just suggestions, they're mandatory. Is it a bilirubin? It needs to be protected from light right away. Ammonia? It goes straight into an ice slurry. If you see a stat order, that means you walk it directly to the lab. No delays. Following these rules is the only way to make sure the sample is still good when it gets tested. So, I want to leave you with this final thought. As a phlebotomist, you're not just drawing blood. You are the very first and most important link in a patient's diagnostic chain. A perfect stick means nothing if the label is wrong. Your attention to detail in these final steps is what protects your patient and ensures they get the right care. Master these steps, and you won't just pass your exam, you'll be an amazing phlebotomist.